all. My talk is going to be on clinical evaluation of ACL injuries. ACL is one of the most frequently injured structure and the most highly studied in the literature. Due to increasing participation in school, more and more kids are now getting injured with ACL injury as among the common diagnoses. Of course, in countries such as ours, in Malaysia, when sports as an industry is the agenda in focus, this contributes to the rise in number of cases. Untreated ACL injuries, especially in this age group, may lead to deterioration in knee function with eventual arthritis in the active young age group of population. Many authors reported that ACL injury is career-ending for an athlete too. With good evaluation, more than 80% are sensitive for ACL injury. Thorough history and physical examination is important to ascertain diagnosis and to determine the appropriate management. So, do you think this is an ACL injury? Often we see such a scenario when a player gets down on the field holding on to the knee in pain. Knowing the ACL gets injured often in competitive sports such as football, soccer, and badminton, or any type of sports which involves cutting activities, landing, deceleration, and rapid change of direction in movement, at the back of our mind we would definitely have this as one of the possibilities. It is kind of fortunate if we get to play back or reverse the recording of such event so that we could watch exactly what had happened just prior to the scene. However, most often than not, we are not as fortunate. So how to make an accurate diagnosis then? We always go back to basics. Never underestimate history taking. So many clues can be obtained when history taking is thorough. Comprehensive physical examination, however, is the mainstay of the diagnosis. Most of the time, history and physical examination alone are sufficient to diagnose an ACL tear. However, in some doubtful cases, certain imaging modalities would be helpful. However, let's focus on the first only. From the history, we can actually obtain information on the mechanism of injury as well as symptoms. A thorough history involves extracting detailed information on the timing of injury, whether it is acute or chronic, whether the swelling was immediate or delayed. Immediate swelling, as we know, is highly suggestive of ACL tear. However, sometimes partial tear doesn't give the same history. So how exactly did the injury happen? This will give information on the mechanism of injury. What are the symptoms that the patient is experiencing? Is there pain besides giving way? Or is there any other symptoms? When the ACL is lax, excessive movement of the knee will jeopardize the meniscus and cartilage as well. Hence, it is common to find meniscus or cartilage lesion as a concomitant injury, especially in chronic ACL. So which activity can cause instability? What are the precipitating or the worsening factors here? Could it be walking on even ground or walking on uneven ground, or maybe the use of staircase? Commonest mechanism of injury is non-contact sports, which involves 70 to 80% of cases. And often the ACL fails when there is abrupt change in direction on a weight-bearing knee with the knee at or new field extension. At this moment, the body is bent forward, the hip is abducted, and the knee is internally or externally rotated. Many a times, the planted foot is pronated at this point as to allow rotation to occur. And in addition to the rotation, when the valgus force to the knee is applied, then it makes the ACL to fail. For most athletes, this maneuver is something that they do every day during training, and they get adapted and rehearsed many times without any problem. Hence, it has been postulated that some other factors might contribute to the failure. Eccentric quadriceps contraction with late hamstring activation could be one of the possibilities. And remember this three-piece: planted foot, pivot, and pop sound. When all of these are present in the history, highly likely that it is an ACL tear. So the knee has 6 degrees of freedom and 3 directions of movement, namely anteroposterior, varus valgus, internal rotation, and external rotation. Being the main stabilizer of the knee, The ACL provides both translational and rotational stability. Hence, physical examination is aimed to assess AP translation as well as rotational movement. So there are three common tests performed to assess the ACL integrity: the anterior drawer test, the Lachman test, and the pivot shift test. Lachman test is the most sensitive among the three. In supine position, and the knee is flexed at 30 degrees to ensure that the hamstring is fully relaxed. One hand applies an anterior force on the tibia while the femur is stabilized using the other hand. Always make sure that the medial step off is normal before starting, or else a false positive Lachman will be obtained. Positive test means when there is a visible anterior translation of tibia in relation to the femur, or sometimes perceived sensation of giving way. We then quantify the translation as to grade the Lachman test to 1, 2, and 3 and assess the endpoint whether it is firm or soft or marginal. We compare with the other side with the contralateral knee as to get the side-to-side difference. If we look at this chart, sensitivity of Lachman test from various studies range from 77% to 96%, and specificity ranged from 68% to more than 95%. Katz and Fingeroff compared the results between acute ACL less than 2 weeks injury to more than 2 weeks injury, and they found that the sensitivity of Lachman is higher in the latter group, but the specificity remained unchanged. It is not easy to perform the test after an acute injury, mainly due to pain and swelling. Sensitivity were reported by Van Eck et al. To be higher when the test was performed under anesthesia as compared to without anesthesia. This could be due to complete muscle relaxation when anesthesia is given. However, the specificity was found to be slightly lower with anesthesia. Gupina, in his study comparing all tests for ACL, found that specificity was only 68.8%, which is much lower result as compared to other studies, although sensitivity was comparable. Comparing complete versus partial ACL tear, LeBlanc et al. Found that the sensitivity of Lachman test is much lower in the partial tear group. This could mean that in some cases of partial ACL tear, Lachman test may be negative because translation is prevented by the remaining fibers of ACL. For this to occur, a significant amount of ACL fibers have to be intact to prevent the excessive movement. An intact ACL prevents forward translation of tibia. We know that the main function of the ACL is to prevent forward translation of tibia at all angles of knee movement. So based on this fact, this anterior drawer test is aimed to reproduce the symptom. With the hip and the knee flexed at 90 degrees and the foot stabilized, an anterior pull on the tibia is applied. So similar to Lachman test, making sure that the medial step off is normal before starting is essential, or else a false positive ADT is the result. So if the test is positive, there will be a visible anterior translation of the tibia in relation to the femur, which can be quantified or estimated in millimeters. This is compared with the contralateral knee to determine the side-to-side difference and to grade the laxity into 1, 2, and 3. Now let's look at this chart. Various studies showed that sensitivity for this test varied from 22% to 92% and specificity ranged from 75 to 100%. Similar to Lachman test, Katz and Fingeroff found that the ADT is more sensitive when performed after 2 weeks post-injury, but the specificity remained high in both groups. Sensitivity and specificity were also found to be higher when done under anesthesia compared to without anesthesia. The pivot shift test among the three is the most specific to ACL laxity, and to many orthopedic surgeons dealing with ACL injury, a positive pivot shift test after ACL reconstruction is quite crucial in determining the clinical outcome. Unlike Lachman and ADT, which are unidirectional, the pivot shift test assesses the rotation by applying multidirectional loads through a range of motion. Basically, it involves reproduction of event perceived by the patient as giving way, that occurs when the ACL is no more functional. This test involves a combination of internal rotation and valgus torque while moving the knee from extension to flexion or flexion to extension. In full extension, the tibial subluxes upon femur when internally rotated and valgus force is applied. As the knee is brought into flexion, a visible reduction of tibia upon the femur occurs while maintaining the internal rotation and valgus forces. This happens at about 30 degrees of flexion when the iliotibial band passes posterior to the center of rotation, pushing the tibial plateau backwards inside the joint line. So due to the relative complexity of the test, it is said that this pivot shift test is rather subjective as it is highly dependent to the technique and experience of the examiner, which means a negative test may turn out to be a false negative instead. So looking at this chart, for pivot shift, the sensitivity range from 24 to 86%. It is interesting to note that the specificity were reported to be consistently high, with lowest figure of 81% without anesthesia, which improved to 98% with anesthesia. Again, upon comparing sensitivity between complete and partial tear group, LeBlanc and co-authors found a lower percentage in the partial ACL group. Although all the three tests have shown adequate accuracy in making a diagnosis of ACL injury, there are still some limitations in their clinical use involving acute injury or when done in clinic setting means without anesthesia or when ACL is partially torn. So this new test called the liver test is said to be more reliable than the standard ACL test. It was introduced in 2005. It is done with patient supine and the knees are in full extension on a hard surface such as a couch. The clinician stands at the side of the patient and places a closed fist under the proximal half of the calf. This flexes the knee slightly. With the other hand, a moderate downward force is applied on the distal third of the quadriceps. The patient's leg acts as a lever to a fulcrum. The clinician's fist acts as the fulcrum. If the ACL is intact, the heel rises up off the couch. This occurs because the force on the quadriceps offsets the force of gravity on the lower leg, and the knee rotates into full extension before the heel goes up. With a torn ACL, the ability to offset this force of gravity is compromised. The tibial plateau then slides anteriorly in relation to the femoral condyle, and the gravity brings the heel down further on the couch. Raymond et al. In his systemic review with meta-analysis on the accuracy of design reported a pooled sensitivity to range from 55% to 95% and specificity of 88% to 98%. So due to the heterogeneity of most of the studies, they concluded that this test can moderately change post-test probability to rule in ACL tear. Because it is simple to do, this may be used to complement other tests, especially in the acute stage and in cases of partial tear. Of course, more investigation is needed to clarify whether it really can give an added value in the diagnosis of ACL tear. Apart from history and physical examination, clinical evaluation can be complemented by certain investigations, specifically imaging modalities such as stress view and MRI. Appropriate imaging modalities such as plain X-ray, especially in the acute stage, is important to rule out avulsion fracture, and in chronic stage, we want to look at the joint space as well as the alignment. The stress view can be done to objectively measure the anterior translation. So we do MRI mainly to assess any concomitant injury to other ligament, especially the meniscus and the cartilage. And it was found to have sensitivity of 86% with specificity of 95%. The use of instrumented laxity assessment using tools such as KT arthrometer, KT1000 or KT2000, rollimeter or inertial sensor, etc. is mainly for research purposes. And of course, last but not least, diagnostic arthroscopy can be performed to diagnose an ACL tear if this is needed. So take-home message. To effectively evaluate an ACL injury, thorough history is essential. Comprehensive physical examination remains the mainstay of diagnosis. Lachman test has the highest sensitivity and specificity. Pivot shift test is highly specific but lacks sensitivity. ADT is useful in chronic ACL injury but not for acute. Liver test may be used as a complement. And stress view and MRI can be used as an adjunct to making the diagnosis of ACL injury. With that, I thank you.